All right. Good evening. I think we're at the top of the hour. So we'll probably wait an additional 30 seconds or so to have additional attendees join before we get started. All right, so we'll go ahead and get started. So good evening, everyone, and welcome to the Living with Skin Cancer Symposium. So I'm Dr. Vincent Ma, a medical oncologist at the University of Wisconsin, and I'm delighted to welcome you all to this inaugural collaborative event between the AIM at Skin Cancer Foundation and the Big Ten Cancer Research Consortium. We're very pleased to have so many patients, caregivers, family members, and healthcare professionals joining us tonight. And so I'll actually be co-hosting this event with Dr. Sarah Wise, a medical oncologist at Rutgers University, and Ann Gast from the AIM at Skin Cancer. And so tonight, the symposium is intended to really promote our shared mission to provide expert-led education for people affected by skin cancer. And so over the course of this evening, we'll have a tremendous lineup of specialists across multiple institutions from the Big Ten, that will review several important topics, including what to expect while on immunotherapy, management of recurrent skin cancer in immunocompromised patients, care considerations for older adults, and promising clinical trials in non-melanoma skin cancer. And this will be followed up by a live Q&A session. And so before we actually get started, I actually would like to introduce Anne from AIM at Skin Cancer, who will introduce herself and really go through and explain how viewers can actually submit their questions during the program.
Thank you. Thank you, Dr. Mon. Thank you, of course, to all of our panelists. We're very excited. I want to welcome everyone who is joining us this evening. I'm Ann Garst-Taylor. I'm the Director of Community Engagement for AIM at Melanoma, which is the parent company for AIM at Skin Cancer. And I'll have an opportunity later on to tell you more about our foundation. But right now, I just want to start by saying how delighted. I want to join Dr. Mon saying how delighted we are to be co-hosting this symposium together with the Big Ten Cancer Research Consortium. We are very excited, and we hope this is the first of many. I will stick that in there in the beginning. Thank you to Dr. Ma and Dr. Weiss for serving as our moderators, and of course to all of our panelists for their collective wisdom. We know that there's going to be questions for our panelists today for our groups. And so what we've done is we have scheduled a 30-minute live Q&A session at the end. I wrote to everyone who signed up to attend this evening's event. I offered you the opportunity to submit your questions early, and some of you did that, and those have been passed on to our moderators. However, you are still welcome to submit your questions. While our presentations are going on, you'll be able to do that either A, because you are watching us through Zoom. If you look at the bottom of your screen, you will see a tab at the bottom that says Q&A. Please put your questions in there, and Dr. Weiss and Dr. Ma will be able to see those and decide which questions should be answered by which panelists. If you, however, are watching us on AIM at Skin Cancer or AIM at Melanoma's social media platforms, YouTube or Facebook, then you will have to submit your questions into the comment field there, but then we will grab those from the comment field and move them over into the Q&A tab for our moderators. And so with that, I'm passing the baton to Dr. Weiss, who is going to introduce our first group.
Thank you so much, Anne. As Anne and Dr. Ma have stated, we're so excited for the program tonight and for everything that we're going to be sharing with our speakers. So again, I'm a medical oncologist at Rutgers Cancer Institute, and I co-chair the Big Ten Clinical Trials Working Group for the Skin Cancer group. We are going to kick off now with the speakers. And so our first presentation is what to expect while on immunotherapy. So I'll ask our speakers to keep themselves on camera, and then everyone else will turn off cameras and go on mute. So we'll move forward with the first talk.
Thank you so much for having me. My name is Tariq Hakel. I'm a medical oncologist and a clinical assistant professor at the University of Michigan, the Rogo Cancer Center. And today I'm joined by two wonderful colleagues as well, Dr. Shruti Renati from dermatology, also clinical assistant professor at the University of Michigan, as well as Dr. Claire Verschregen, medical oncologist and professor at the Ohio State University, the James Cancer Center. So today, our session will be focused on what to expect while on PD-1 therapy. These are our disclosures for all three of us. And today, we're focusing on three main topics. So we're going to do a brief introduction as to what PD-1 therapy is, a brief overview of how it is used for the common non-melanoma skin cancers, and then do also a brief overview of the PD-1 related side effects and how we can best manage those. So to kick us off, so what is immune therapy or immune checkpoint inhibitors? They are usually monoclonal antibodies. Those are proteins that block other proteins on immune cells or tumor cells. There's quite a few of those. The more common ones are CTLA4, PD-1, LAG3, and so on. And the goal of what these antibodies can achieve is to mount an immune response by activating and allowing the immune cells, most commonly called the T cells, to actually go and attack the cancer cells. So, or at least that's the mechanism we hope to achieve with these therapies. So more specifically, PD-1 inhibitor therapy is really one of the most, or if the most common immunotherapy we tend to use, especially in non-melanoma skin cancers. And these are a few names, of drugs that have been quite advanced in this field. So cemiplimab or Libtayo, pembrolizumab or Keytruda, nivolumab, Opdivo, and retifanlimab. And again, the whole purpose of the PD-1 inhibitors are to sort of allow the T cell or the immune cells of our own bodies to actually mount and recognize the tumor cell to allow for a response against the cancer. So how are these PD-1 inhibitors really applied in our non-melanoma skin cancers? And I'll start with our most common skin cancer, which is basal cell carcinoma. So it is the most common, yet when we catch it early, the cure rates are really high, and usually that's done with surgical resections or Mohs surgery. However, in select cases, these basal cell carcinomas can be in very hard to treat anatomic locations of the body, or sometimes locally advanced or bulky that doesn't allow for a safe surgery or a successful one. In that case, sometimes we go to drug therapies to help us, shrink these tumors to allow for a better surgery or even treat them with drugs alone. Usually the first line or the first treatment that we reach for in this setting is pills called hedgehog inhibitors. The two approved ones are sunitinib and vismodegib. They are very effective, though they can be quite hard to tolerate, especially long-term. PD-1 inhibitor therapy, usually with cemiplimab, which is given intravenously, is either a second-line therapy that can be used when these pills that I mentioned do not work well or quit working or are not well tolerated or contraindicated. Cemiplimab in this setting can be quite effective up to 40% of the time. Moving on to the second most common skin cancer, the squamous cell carcinoma of the skin. Similarly to basal cell carcinoma, this is, if found early, can be cured with, again, local therapies and surgery. However, I would say more commonly, squamous cell compared to basal cell can unfortunately be found to be locally advanced or metastatic, meaning moving to other organs other than the skin, in which case surgery may be challenging or not deemed to be quite successful or not really helpful, right? So in squamous cell carcinoma in these settings, cemiplimab actually is the first-line therapy that is FDA approved in this setting. And it's actually quite effective in 50 to 60% of the time for this specific type of non-melanoma skin cancer. More recently, actually, we've had more data to support using cemiplimab. We call it neoadjuvantly, so before surgery, And we have data to support that it actually helps improve surgical outcomes and cures for select patients with squamous cell that is locally advanced, where surgery alone may not be the best thing by itself or successful by itself, or maybe too morbid, meaning to cause a lot of complications and healing issues. And again, it may not get all the cancer. And more recently, also, we've had it approved in the adjuvant setting, meaning patients that have had surgery and then some radiation sometimes after surgery, and that can be used after surgery to also improve the cure rates and outcomes for patients. So cemiplimab has moved also in squamous cell for patients that can also have surgery in select situations. Merkel cell carcinoma is a rare skin cancer with neuroendocrine features. Unfortunately, it's rapidly growing and aggressive, but luckily it's rare. So we only have 3,000 cases a year in the US, but almost 40% of those are recurrences. And when recurrence happens, meaning when the cancer comes back, we can have really higher risk of morbidity and mortality, especially when local, regional, or stage 4 metastatic disease develops. In Merkel cell, we have quite a few PD-1 inhibitors actually approved in this setting. So we have pembrolizumab, which can be given intravenously or subcutaneously. Nivolumab also can be given intravenously or subcutaneously. Retifanlimab is IV. There's also avelumab, which is a PD-L1 therapy in this setting, and they're all options. They're all first-line therapies that can be given in locally advanced or metastatic Merkel cell. Now, nivolumab or Opdivo has also had some data to support using it before surgery in Merkel cell that is also locally advanced, when surgery may not be by itself curative, or maybe, again, unsuccessful or too morbid. So there's also data to support using it before surgery for Merkel cell. So what to expect while on PD-1 therapy? So the first thing is the schedule and how it is given, right? So I mentioned quite a few names of PD-1 therapies, most of which are given intravenously. Usually a typical day is that you come into the cancer center, you get blood work, and then you see your healthcare professional. And then if you feel fine and the blood work is fine, we say, okay to treat, and then you go get the treatment. I would say majority of these PD-1 therapies are IV, though more recently, pembrolizumab and nivolumab, again, which are Keytruda and Opdivo, they have new formulations and they are given sub-Q, which some of our patients report that it's easy to get because it's quick. So it's given in 5 to 10 minutes versus the infusion can take up to an hour to be given. So the benefit, these are given every few weeks, depending on which drug we use. I would say for the most part, they're given every 3 to 4 weeks, again, depending on which drug we use and depending on what cancer we're treating. Now, the benefit and how to measure it, a lot of the non-melanoma skin cancers are cancers that we can actually see on exam and feel clinically. But we couple that also with blood work and imaging. And all these tools are used to assess, is the cancer really responding? And is the treatment really helping? And finally, we'll talk about side effects and how to manage them, because that's at least half of what I do in clinic. So the side effects, I would say for the most part, they're driven by an unwanted inflammation. So we're trying to rev up the immune system against the cancer to get a quick response against it. But sometimes what can happen is that we activate the immune system and it can overshoot. And that unwanted inflammation can go and attack a normal organ or tissue. And you can see on the figure that it can really affect about any organ system. So we're going to go through them in a little bit of detail. I'll start with the first two. So fatigue is the most common side effect that we see. It affects about 90% of patients. In a small percentage, it can be quite severe and affect the patients and their ability to function and do activities of daily life. It can start as soon as after the infusion, and it can last even after we hold therapy. We always look for other causes of fatigue, but if we can, then we have to say it is related to the drug therapy or PD-1 therapy. Treatment, if it's really bad, we advise rest. However, in Moderate fatigue, we recommend increasing actually physical activity. It's like going to the gym and kind of training your body to, to acquire stamina and keep that going. But in rare cases, fatigue can be quite severe and debilitating, and patients may have to spend hours in bed all day and be unable to do activities of daily life, in which case then holding the therapy may be helpful sometimes. Infusion reactions can also be quite common. So these are like allergic-like reactions that could happen when patients take the infusion or shortly after. It can affect up to 10% of patients. And the treatment usually is we stop the infusion, we assess the patient, and then depending on the case, we can give them medications supportive like Tylenol, antihistamines, and so on. And when deemed safe, we can resume the infusion at a slower rate. And then for future infusions, we try to plan better and give pre-medications and slow the infusion so that patients can better tolerate it. With that, I'll pass it on to my colleague, Dr. Renati, who will go over the skin side effects of PD-1 therapy, and Dr. Vershrigen will take over after that for the remainder of the time to discuss all the other side effects of PD-1 therapy.
Awesome. Thanks, Dr. Haykel. Like you mentioned, I'm Shruti Renati, one of the dermatologists at University of Michigan with a special interest in skin side effects of cancer therapies. So with PD-1 therapy, there's quite a broad range of who gets these skin side effects. Does depend on the patient population and the type of cancer and type of PD-1 inhibitor we're using, but about 16 to 40% of patients will have some skin side effect from treatment. But most of the time it is low grade and manageable with a variety of treatments that some are over the counter and some are prescription. There's also some data that sometimes when patients get skin side effects from PD-1 therapy, it's actually associated with improved treatment outcomes. Like Dr. Haykel mentioned, we're kind of trying to rev up the immune system to try to treat the cancer, and sometimes revving up that immune system can lead to certain skin side effects. The more common side effects we'll see is rash. There's a variety of different rashes. A lot of times they're itchy, sometimes they're more painful, and sometimes they have no symptoms at all. And we have different names for the variety of different rashes that we see. Some patients will get itching without a rash, so that can also be a skin side effect of treatment. And then there's a condition called vitiligo, where the patient's own immune system will start to fight some of the pigment-producing cells in the body, and that can lead to loss of pigment on certain parts of the skin. And sometimes it's just in some areas of the skin, and sometimes we'll see it more widespread. So if you're dealing with skin side effect, I think very reasonable to reach out to your oncology team, and they'll get dermatology involved if needed. We'll treat with things like topical steroid creams and ointments, gentle skincare, which I'll go over as well today. And then antihistamines can be helpful for itching. And then when needed, we have some other pill and injection treatment options that we'll use. General skincare, a lot of immunotherapy cancer treatment in general can lead to more dry and sensitive skin. So even before a patient develops a skin rash or skin side effect, I'd recommend kind of following some general skincare guidelines. We like mild soaps that are fragrance-free. The ones that are marketed as antibacterial tend to be a bit more drying for the skin. Sometimes they're needed, but if you don't have a need for that, it would actually be better to use a soap that's not antibacterial because it will be less drying. When it comes to moisturizer, it's really good to get that on right after a shower or bath. I tell my patients try to get the moisture on within 2 minutes of coming out of the shower or bath because it does work better when there's still a little bit of dampness on the skin there. And then when picking a moisturizer, try to get some thicker creams or ointments. Those tend to work better than the lotions that are a bit runny. Still stick to fragrance-free if possible. Laundry detergent as well, kind of a free and clear laundry detergent. And there's more options for that available at the store now. Skip the dryer sheets, skip the fabric softeners, which often have a lot of additives. And then avoid hot showers if possible. Lukewarm is better. And if you are going to take a hot shower, try to keep it really short, like 5 minutes or less. And I'll go to my next slide. There are sometimes severe skin reactions that occur, but it's rare. So 3% or fewer patients receiving PD-1 monotherapy will get severe skin reactions. So things that I would tell patients to watch for the more severe reactions is if you're noticing sores or painful spots in the mouth itself, eye symptoms, or sores and painful spots involving the groin skin. If the rash is becoming more painful, that could be a sign of something more severe. If you're noticing like blisters, which means it almost feels like there's fluid-filled bumps on the skin, or if the skin starts to peel, especially if it's peeling and you're noticing kind of like the skin is a bit bloody underneath and painful. And then if your rash comes along with this feeling unwell, fevers, chills, those could be signs of something more severe and even more reason to reach out to your oncology team. And then the next slide, we have some pictures of the more severe skin reactions. Again, this is rare, less than 3% of patients get the more severe ones, but you can see it's a bit more widespread. Sometimes there's blistering involved as well. All right.
Dr. Verschregen.
Here. Okay. Can you hear me?
Yes.
Yes, good. Okay, well, thank you very much, Dr. Hekal and Renati, to include me in this presentation. And what I really want to tell patients is that giving immunotherapy is really like a football team. We are all part of the team, physicians and patients and nurses and pharmacists, the people that are delivering the medicine in the infusion suite, etc. So it's very important that the patient is participatory, and if any of the symptoms shows up, they really need to contact the nurse or the physician or whoever they were told to contact and discuss what to do with them. So with cemiplimab specifically, in our series, we had about 10% of people that had side effects that were severe enough that we really had to intervene. And about another 40 to 50% where the symptoms were mild. And so less intervention were necessary. And about half of the patients have no symptoms. But one of the most common ones is diarrhea and abdominal cramps. So if you feel that you have these symptoms and you have more than one episode of diarrhea and it's fairly liquid, it's really time to call your team so that they can first hydrate you and then decide if you need to go on steroids, which is the first line of treatment for this type of, in fact, for almost any immunotherapy side effects. If the steroids are not working, which I have seen in some patients, then we have other drugs that we can administer, but it can take up to 2 to 4 months to resolve the symptoms. So don't be hopeless, it will go away, but you really need to work with your team and listen to their advice to make sure that you get the best care possible. Next slide. So another side effect that's a little bit less common, especially for patients with skin cancer, is basically an inflammation of the lung that causes shortness of breath or cough. It is much more common in people that have lung cancer and are treated with immunotherapy. But if you develop a hacking cough or a dry cough, you're short of breath when you take a flight of stairs, it's really time to call your team again because they will listen to your lungs. They may even need a CAT scan to diagnose the condition, and then they will decide whether you need to, whether you have a reaction to the immunotherapy and whether you need treatment or not. It's important that you call very quickly so that you can get the treatment to reverse the condition. And again, it may take 2 to 4 months with a complete resolution in most patients. Next slide. And I'm giving these side effects in the order of frequency. So the more I go in my presentation, the least we see these types of side effects. So liver inflammation, which causes basically an immune-related hepatitis, not related to the virus, but related to the treatment, that's usually seen on the blood draw when you come for treatment, and we see that the liver function tests are elevated. But you can have some fatigue, some nausea, some lack of appetite, some abdominal pain, and usually that will be in the upper part of your abdomen. So if that happens, you should also call your team. If your doctor diagnoses it on your blood work, it depends a little bit on the pattern of what is elevated, but if the bilirubin becomes elevated, this is really an ominous sign that something needs to be done. And steroids by themselves are probably not enough in most of the case, and you need to go to other drugs such as tocilizumab, which is a drug that's used a lot in rheumatology to treat various autoimmune conditions. Next slide. There is a lot of hormones imbalance that we can see after administration of immunotherapy, because the immunotherapy goes to destroy all these endocrine organs. And when I say hormones, it's not just sex hormones. In fact, that's the least problem. The biggest problem is really the thyroid hormones or the adrenal hormones. And when those organs don't function well and your hormonal level goes down, or first goes up when the organ is killed and release all the hormones, and then will go down, you will not feel well. So that, again, this is something we watch each time you come for your infusion, making sure that all these levels are normal before we give the next infusion. So we usually detect it before the patients really can feel it, but sometimes it can be very acute. And if you feel all these side effects, especially acute fatigue, and weird side effect and malaise that you don't feel well, call your team immediately and they can verify what's going on. One of the symptoms that comes really out of the blue is type 1 diabetes, where the pancreas gets affected by the immunotherapy and does not secrete the insulin anymore, and the sugar rises quickly, and people really don't feel well, and they need to be treated immediately with insulin replacement to help getting the sugar back to normal. Next slide. So the treatment approach again is these are for those hormonal effects. Is that usually those are not reversible. So you may end up having to take a thyroid replacement such as levothyroxine, or some steroid replacement such as hydrocortisone for the rest of your life. A lot of people in the community, even not on immunotherapy, do have, for example, low thyroids and are already taking these types of pills. So these are common medication that we give to patients. But if it happens after immunotherapy, we definitely want to replace the lack of hormones that you have. And I already mentioned the insulin. So next.
Dr. Verstraegen, we're almost at time. I just wanted to...
Okay, I think that's my last slide. Next. I'm going to go very quickly. These are the musculoskeletal manifestations that we get, and treatment always starts with corticosteroids, physical therapy, anti-inflammatory, and then if that doesn't work well, then we would send you to the rheumatologist. Next slide. These are other manifestations. They are extremely rare, less than 1 or 2% of the patients, but they can happen, and we will diagnose them while we examine in the clinic and treat them accordingly. Next. I think that's it. That was my last slide. Thank you very much.
And yeah, with that, we conclude that what to expect with PD-1 therapy. Thank you so much for my colleagues.
Yes, excellent. Thank you so much. I think that was a really excellent overview of what to expect with immunotherapy, the toxicities and expectations. So I'm very excited now to sort of introduce our second group, which will be highlighting our second topic, which is management of multiple and or recurrent squamous cell carcinomas while immunocompromised. And so I'd like to ask those who will be speaking for this to have their cameras on, and all the others to have their cameras off. Thank you.
Great. Well, I will open up. I am Dr. Annika Weinhammer, and I will be presenting on this topic with Dr. Mackenzie Azel, who is a dermatologist at UW, and also Dr. Frank Warden, who is a medical oncologist at the University of Michigan. So I'm now going to share my slides. Perfect. So I will open up with a case presentation from my high-risk skin cancer clinic, where I see a lot of immunosuppressed transplant patients and other patients with a high burden of skin cancer. I wanted to kind of walk you guys through whether this resonates with yourself or put you into one of my patients' shoes as they navigate through our dermatology clinic over a 1-year period. So this is one of my patients. He comes in for a Mohs surgery, 2 Mohs surgeries, 2 repairs with 2 additional biopsies, and has activity restrictions, bandaging, and wound healing for months. He then comes in for visit number 2, has another Mohs surgery, another excision with 2 repairs, more activity restrictions, more bandaging, and wound healing for months. Then visit number 3 with another skin exam, 4 biopsies done, 4 more skin cancers to treat. He then comes in for an excision and a scrape and burn procedure called an ED&C, again with more limiting activities and bandaging. Visit number 5, another skin exam with 4 more additional biopsies and an excision done at that visit. Visit number 6, he has 3 more ED&Cs, 4 more biopsies with 3 more skin cancers to treat. He then comes in for visit number 7 for another excision, 2 more ED&Cs. Now visit number 8, another skin exam with 3 more cancers to treat. Visit number 9, 2 more Mohs surgeries, 2 more repairs. And visit number 10, a final Mohs surgery with 1 more repair. It equated to 10 total visits, a traveling time of over 40 hours. Time spent in our clinic was approximately 36 hours. He had activity restrictions for about 14 weeks with really no breaks from healing, bandaging, or wound care throughout the entire year. Stories like this is what has motivated me to create a high-risk skin cancer clinic where I try to limit the amount of procedures and the overall burden of skin cancer. This leads me to the topic of cancer-related fatigue, which is something that my patients suffer from quite severely. And may resonate with some of you in the audience. It's a distressing, persistent, subjective sense of physical, emotional, cognitive exhaustion related to cancer and/or its treatment. It's really more severe and debilitating than typical fatigue and not relieved with sleep and rest. There's a lot of data in the general oncology literature that has a multifactorial etiology for this, but a lot of data to support upregulation of pro-inflammatory cytokines. So kind of a process that's directly related to the cancer that they are dealing with. It really has a significant impact on my patients with a high tumor burden or high amount of skin cancers because they have so many surgeries with long recovery times and bandaging and restrictions, really no remission. So a lot of my immunosuppressed patients can get more skin cancers with time, a multidisciplinary needs. And then for my solid organ transplant recipients, this is all compounded by the fear of losing their transplanted organ. So my clinic is designed to really minimize the cancer-related fatigue that my patients have to suffer with. And there's a few topics that I'd like to quickly discuss. One is early intervention with chemopreventative medications to decrease overall skin cancer prevention. Dr. Mackenzie Azel will briefly touch on some of our topical chemotherapy agents. So I wanted to talk about nicotinamide first, which is actually just an over-the-counter supplement, a form of vitamin B3. That is indicated for anyone who's had 1 or more non-melanoma skin cancers. And it can actually decrease the amount that patients form by up to 25% over time. They take the supplement 500 milligrams twice daily. And because it's just an over-the-counter supplement, it really has minimal side effects and is very well tolerated. The second medication I use very often is acitretin. The exact mechanism is not entirely known, but it definitely has some anti-proliferative effects, meaning like it decreases cancer progression. It also regulates growth factors and has immune modulation. And it's very effective at decreasing squamous cell carcinomas. It does have a larger side effect profile than over-the-counter nicotinamide, but is something that can be very well tolerated if we dose the medication appropriately to the lowest tolerated dose. A couple other tips is to minimize and combine visits whenever possible, really tailoring the management of care that aligns with patient goals. So a lot of shared decision making and deciding on what goals the patient wants to prioritize first. And then using non-surgical treatments when appropriate, which Dr. Azel will highlight on her slides, and I will turn it over to her next.
Great, thank you so much. So I'll be talking about some additional treatment options beyond surgery. We started today's webinar with the discussion of immunotherapy, but for most patients with skin cancer, statistically speaking, these are going to be skin cancers that are readily treatable with local therapies. I'm mostly going to focus on the approach to management of multiple squamous cell carcinoma in the setting of immunosuppression as opposed to recurrent, as recurrent squamous cell carcinoma does require more aggressive therapy. But when it comes to patients who have a high burden of non-melanoma skin cancers, as Dr. Weinhammer said, it is really in our best interest, in the patient's best interest, to explore often less invasive approaches to treatment. When it comes to surgical approaches to treatment, Dr. Weinhammer mentioned Mohs surgery and excision. For many patients, they'll get these procedures done under local anesthetic. And they can often be quite time-consuming, particularly in Mohs surgery, which involves checking the margins of the tumor under the microscope while the patient's still waiting in the clinic. An excision takes a wider piece of skin with normal-appearing skin around the tumor and can be quicker. But even quicker than that is the procedure called electrodesiccation and curettage. So we use this treatment only in patients with very minor types of skin cancer, so often superficial squamous cell carcinoma in situ, as well as low-risk basal cell carcinomas, such as nodular or superficial basal cell carcinomas. And I'll talk a little bit more in detail about what that looks like, as well as some non-surgical treatment options, again, focusing on low-risk tumors and the patients who are suffering from multiple skin cancers. Next slide. When it comes to the treatment of non-melanoma skin cancer, there's not a one-size-fits-all approach. So I think it's super important for patients to realize that the kind of menu of options that your doctor presents to you is very highly dependent on multiple factors. It not only depends on what cancer type is at play, oftentimes basal cell or squamous cell carcinoma, but what subtype of cancer. So for basal cell, there are certain higher risk versus lower risk types. The approach to treatment also depends on specific features of the tumor, such as how big it is, how deep it goes, and how well differentiated or poorly differentiated it is. The location is also important. Low risk body parts can be treated less aggressively than high risk body parts, such as the face. The patient's overall age and health will impact what type of recommendations are made for treatment, as well as the patient's preferences regarding the cosmetic outcome. And as I mentioned, whether the tumor is an initial episode versus recurrence is also very important, with recurrence often requiring more aggressive treatment. Next slide. Our group was assigned the topic of squamous cell carcinoma in the setting of immunosuppression. So I just want to highlight that immunosuppression is considered one of the risk factors for more aggressively behaving squamous cell carcinoma, as you can see here, making it one of the high-risk features. So in a given patient that has immunosuppression, we're generally going to be more cautious, more conservative with our treatment recommendations. Next slide. So electrodesiccation and curettage is a technique that I want to describe for low-risk tumors. This involves numbing up the site of the skin cancer that's been proven by biopsy, and scraping away the tumorous tissue, which is often friable or squishy compared to normal skin. And then the biopsy site is cauterized to stop the bleeding and destroy additional skin cancer cells. And then this process is repeated several times. It leaves a superficial wound, very similar to the wound left after a shave biopsy, and it leaves a circle or oval-shaped scar. Next slide. Some of the advantages of this approach to treatment is it can be much quicker than a patient having to sit through surgery, particularly Mohs surgery. It can take just a few minutes. It's very effective for small and low-risk skin cancers on low-risk body parts. And it's also relatively inexpensive. Some of the downsides of this approach include that the tumor is not checked under the microscope to confirm negative margins, which is okay when we use it appropriately in low-risk tumors. But sometimes patients may express some anxiety over that, and for those who do have a lot of anxiety related to their cancer treatment, it may not be the best choice. The other issue is that sometimes the outcome of the scar is suboptimal, depending on the location. It may be undesirable to have this round or oval-shaped scar. Next slide. Another approach to the treatment of low-risk skin cancers in patients who are affected with a high burden of multiple skin cancers is topical medications, which are applied to the area of the biopsy and then surrounding skin. Usually these are going to create a rash during the course of treatment, which is a sign that they're working effectively. And then after using the treatment for several weeks, and that reaction subsides, it should leave normal appearing skin behind. Next slide. One of the nice things about the approach of topical medications is there's no additional surgical approach and no additional scarring. And the patient can do the treatment at home without having to return to the clinic for the treatment. Again, this is only useful for superficial skin cancers such as squamous cell carcinoma in situ and superficial basal cell carcinoma. Similar to the electrodesiccation curettage, it does not confer negative margins. And this is a longer treatment requiring several weeks of application with a lower cure rate. Next slide. Radiation is the use of a focused beam of energy onto the skin cancer. And this is used in very select circumstances, particularly in patients who are not good surgical candidates. You can go to the next slide. For patients who would have trouble withstanding an involved Mohs surgery, for example, an involved repair, radiation can be a good option. It does have a lower cure rate when used as the primary treatment. It does require multiple sessions over many weeks, so it can be extremely time consuming. It does risk potential for scarring or wound formation. Again, this does not confirm negative margins either. Next slide. And then lastly, I just want to briefly touch on what we can do to try to prevent skin cancers topically. So Dr. Weinhammer talked about the use of niacinamide and acitretin that are taken orally to try to reduce skin cancer risk. But there's also a variety of topical skin-directed treatments that can be used to reduce the risk for skin cancer arising within areas of sun-damaged skin. The duration, the frequency of each of these treatments, fluorouracil mixed with calcipotriol and imiquimod, depends on which agent is used. Often these are going to create a rash during the course of treatment. Terbinafulin is a relatively recent addition to this list. And then there's also the use of chemical peels or photodynamic therapy in some cases, with the goal here being to treat the precancers so that they don't evolve into actual non-melanoma skin cancers. And with that, I'll turn it back over to the rest of the team.
Great. Thank you, Dr. Hazel. So I am Frank Warden, medical oncologist at the Rogel Cancer Center in Michigan. And for some of you on the call this evening, you may have an organ transplant. And so as a medical oncologist, I prescribe chemotherapy and immunotherapy. And I just wanted to talk a little bit about how we can use immunotherapy for organ transplant patients and other patients who are immunocompromised. Next slide. So the idea here is that you have a transplanted organ. So in order to avoid rejection, we have to quiet the immune system. So immunosuppressants are given, or the anti-rejection drugs are given, and they deliberately quiet the immune system so that it doesn't attack the new organ. Flip side of that, it makes your cells more vulnerable to becoming abnormal. And this is because the immune system is actively suppressed, and so we can't regulate the cells, and the abnormal cells can actually escape the immune system's ability to regulate or keep those cells in check. Next. So transplant patients, and I treat primarily head and neck cancer patients, face an aggressively higher risk of cutaneous squamous cell carcinomas. So those are primarily what I see as a head and neck medical oncologist. So squamous cells occur in the tonsil and the voice box, but we see a fair number that occur on the head and neck because of the sun exposure that we receive to our head and necks. Transplant patients are 65 to 250 times higher the risk. And so it's really more important, or it's most important to know that when any of you have been diagnosed, just like the other doctors have been talking about, protection is an absolute must, meaning that skin protection with a sunscreen and wearing hats, wearing long sleeve shirts, etc., when spending maximal time out in the sun. And it's not the fact that the patients with organ transplants have skin cancers, because we can all get them. It's just the fact that they grow faster. And so I had a patient come in today, for example, and he said, I had this transplant 7 years ago, and now I have all these skin cancers, and it's because I went on these transplant medications. And I explained to him that the damage was done a long time ago. So this is damage that was done primarily in one's use. When he said, oh, yes, I've been sunbathing a lot. I used to be a lifeguard at a swimming pool. We never wore sunscreen or hats. And so this is an example of someone who developed an intense large squamous cell carcinoma of the ear, who also was a kidney transplant patient. Next. So this has been described earlier about immunotherapy. I kind of like just go over it in maybe a little bit simpler terms here, that think of the immune cell as a police car with two policemen in it. And the police car drives up to the enemy, which is the cancer, the bad guy, and says, the guy driving the car says, stop. And he says, wow, this is a pretty bad guy. I need help. So he turns to the guy who's his sidekick and says, bring your radio in and call all the reinforcements, which are all those inflammatory cells. What happens is the cancer is pretty tricky. It actually reaches through, breaks the glass, steals the radio, and now there's no ability to call any kind of immuno activity into the cancer. So it kind of creates this, on the left side here, this shield around the cancer cell. So when we infuse you with immunotherapy, it's been discussed, what happens is we kind of create a shield over the windshield so that when the cancer tries to break the windshield to steal the radio, it can't. And so when that happens, that shield is destroyed, like you see in the middle picture, and that allows all those immune cells to come rushing into the cancer and to start taking down the cancer. And as discussed, those immune cells are also going to all of the other organs as passenger cells to see if there are things that can be eliminated. And for example, in a transplant patient, we would worry about rejection. All right, next. So this is where the balancing act comes here. Well, first, immunotherapy wakes up the immune system, so we need to destroy the cancer, and then the organ risk. So the organs are at stake, and we've talked about this already. It's been presented very nicely here this evening, but we also worry again about rejection of the transplanted organ. So historically, patients with transplants were excused from clinical trials or were not treated. In fact, if you look at the inserts that are given out by the FDA, will talk about not treating cutaneous squamous cell carcinomas with immunotherapy if patients have transplant. All right, next. So there has been shifts in trying to overcome this and new protocols to kind of bridge the gap, how we can go about doing this. And so there was a study conducted out of Dana-Farber, which is the Harvard Medical System, my friends out there, where they gave cemiplimab, we've talked about, that's one of the immunotherapies, and they gave it to transplant patients. And in order to protect them, we actually talked to the transplant doctors and said, can we change around perhaps some of the anti-rejection medications to include steroids or prednisone, which some of you could be on, but in a little bit different dosing. So higher dose, like 40 milligrams the day before, the day of, and after treatment, 20 milligrams for a few more days later, and then 10 milligrams all the way up to the next cycle. So a cycle of immunotherapy is every 21 days. In addition, they put people on this drug called an mTOR inhibitor, which blocks various pathways in cancers and can have anti-cancer activity. So when those two agents were combined with immunotherapy, what we found is that people responded to the immunotherapy. And response means the cancer shrunk by 30% or more. So all those mutations created by the sun were still amenable to be treated by immunotherapy, even though there was some immunosuppression that was still available to protect the organ. So what they found is that none of these patients, when they were on this mTOR inhibitor and this pulse dose prednisone, as they call it, had a rejection. And the important point was that the median survival was somewhere around 23 months, meaning that half the people that attained a response had long-term responses, and there were some people who had shorter responses. So when we compare this to the general population, so those people we were talking about earlier who receive immunotherapy for their skin cancers who aren't transplant patients, it's really about the same. We don't have to worry about organ rejection here because they don't have that issue, but the responses are really very similar. So we're not doing a disservice to patients by changing things around to protect your organ while we treat you. But certainly, anytime a patient comes in, I always tell them, I cannot make that promise. But you're coming to us as medical oncologists because, as Dr. Azel and the other doctors have talked about, we use those definitive measures first, such as surgery, such as radiation, topical therapies. And we're giving immunotherapy really at a time when the cancer is so advanced that we really can't offer any more surgery or any more radiation therapy. All right, next. So again, the science is advancing, but rejection remains critical. So the takeaway here is that we all as providers need to be involved with your transplant doctors as well as you so we can make a decision that's right for you. So just because this is offered, it doesn't mean that it's something that we have to do, though we believe these are the best drugs that we have available to treat cutaneous or skin squamous cell carcinomas. Certainly there are other alternatives and there are other clinical trials exploring other agents. But I'd just like to leave you with the data here to suggest that I know myself personally have treated transplant patients and have done so successfully without people losing their organs. And as I close, I'd also like to say that we do treat other conditions that are considered immunosuppressed, such as rheumatoid arthritis or psoriatic arthritis or Crohn's disease. As long as those diseases are well controlled with agents that are used to treat those conditions, what I do is I also give the pulse dose steroids after I talk to the doctor who's treating those conditions. And so to offer a little more protection, I will give that same regimen of the steroids as I talked about, the 40 milligrams for 3 days, then 20 milligrams, and the 10 milligrams, along with the other agents they may be taking, along with giving the immunotherapy. And I found that actually lessens the chance of activating the arthritis or the rashes and things like that. So those are potentially other strategies. This is a strategy that can be used when sometimes people are turned away from immunotherapy for immunocompromised states. So with that, I am finished and I'll turn it back over to you.
Thank you to the presenters. That was a great talk, and we're going to move on to the third session. So it's going to be skin cancer management in the senior population, and we'll invite those presenters to come on video.
Hello, everyone. My name is Elizabeth Peterson. I'm a dermatologist at the University of Michigan, and I work with doctors in the Rogel Cancer Center, many of whom you've already heard from. And today we're going to, for this session, we're going to shift gears a little bit and talk more about options for elderly patients or older patients that may not be good candidates for some of the other treatments that you've heard about or the more traditional surgery options. And so today with me, I have a couple of other wonderful doctors from the Big Ten. We have Ashley Preval from University of Wisconsin and Dr. Matthew Ferris from Maryland. And we also have another panelist, Dr. Mark, who will be with us during the question and answer session. He's from dermatology at the University of Indiana. And so we're all here to kind of tell you about alternative options and things to think, considerations for elderly patients, and happy to answer questions after that. So with that, we'll go ahead and get started. Okay. Okay.
Thank you, Dr. Peterson. Good evening, everyone. I'm Ashley Preval, and as Dr. Peterson mentioned, I'm a dermatologist at the University of Wisconsin. Next slide. So I'll be talking about active surveillance for non-melanoma skin cancers. So what does active surveillance actually mean? Well, it generally refers to a treatment strategy of careful monitoring that's often described as watchful waiting. So while some non-melanoma skin cancers can behave aggressively, many tend to grow slowly and are not life-threatening. Typically, the main non-melanoma skin cancers that may be considered for active surveillance include basal cell carcinoma and squamous cell carcinoma. And for the rest of this presentation, when discussing non-melanoma skin cancer, I will be referring to only basal cell or squamous cell carcinoma. Next slide. So what skin cancers are considered low risk? Well, most basal cell carcinomas tend to be slow growing, particularly when they are small. While some squamous cell carcinomas can be more aggressive in certain situations, those that are well differentiated on pathology, so that's usually what the pathologist would see under the microscope, or if they are superficial or in situ, if they are located on the trunk or extremities, smaller in size and not rapidly growing, they are considered lower risk. And this is in contrast to high risk features where monitoring may not be the best choice. And these riskier features might include locations such as the lips and ears. They may be large or rapidly growing tumors. The patients may be immunosuppressed, as we just heard about. And the skin cancers, they may have more atypical cells seen on under the microscope from the biopsy. Next slide. So when would watchful waiting be considered? And to remember, these factors are not always black and white, and there's no one size fits all. This should really be a shared decision between the provider and the patient. So one of the kind of guardrails may be if the patient is over 85 years old. Again, this is just a number, but may, help guide to have the conversation. Frailty or many or severe comorbidities, which may make certain types of treatments riskier, or if there is a decrease or decline in cognition. Limited life expectancy, and there are different types of scales that can be used to determine this. Low risk skin cancers, again, ones that are slow growing or have limited metastatic potential, where the risk of treatment outweighs the risk of the skin cancer. So we've already heard about some of the side effects or risks of treatment for different types of skin cancers tonight. If the skin cancer is not affecting the quality of life or having any functional impairment, for example, functional impairment could include skin cancers that are potentially on the ear and causing, difficulty or pain when sleeping, or skin cancers that are maybe on the nose and inhibiting air passage through the nares. And then patient preference. Next slide. So this is an algorithm that was created to help guide providers in determining whether watchful waiting may be appropriate. And we won't go into detail here, but it highlights 3 key factors that we've already touched on. So life expectancy, the presence of bothersome symptoms, and the tumor risk, including if there are potential consequences of delaying treatment. And important to note that this algorithm was developed specifically for basal cell carcinoma. Next slide, please. So deciding on watchful waiting should always be a shared decision between the patient and their provider. It's essential that patients feel fully informed on their decision and that their goals and values are clearly understood. The quality of life should remain a central priority throughout the process. It's always helpful to involve support systems and caregivers that can add useful information or support the patient. And again, ultimately, there's no one-size-fits-all approach. So having an open discussion with your healthcare provider, including other providers from other specialties, can be really important. Next slide. So finally, if watchful waiting is the agreed upon treatment, we would certainly want to monitor. And what would be the red flags that would maybe suggest that we need to reevaluate treatment decisions? So this would be if the spot or the cancer is rapidly growing, if the patient is having increased pain, if it's affecting their quality of life or functional impairment, if the risk to benefit ratio for treatment has changed. For instance, maybe they were undergoing treatment for something else or had other comorbidities that have since been treated or improved upon. And finally, if the patient's values or goals change. Next slide. Thank you.
Thank you for that great overview of monitoring. Next, I'm going to talk to you about some of the non-surgical options should surveillance not be quite the right option, but you're not quite ready to undergo surgery for skin cancer. So after a diagnosis of skin cancer, surgery is almost always, at least discussed and often recommended. And the reason for that is for many of the reasons you've heard before. We know that we can assess the margins and see if everything is gone. We know that in many patients, it's well tolerated. They can heal with good cosmetic effects afterwards. But in older folks, sometimes there's more challenges in that wound care is difficult. Transportation to and from for multiple surgery appointments can be difficult. And some patients are just downright tired of surgery as well, too, and perhaps don't want to have to do this, especially for a low-risk skin cancer that may or may not ever go on to cause any problems. So surgery is not for everyone, and definitely older folks fall into this category. Other options do exist, and as we've heard about many of them, monitoring, as Dr. Preval just talked about. We've heard about some of the cream treatment options, and I'm going to go into a little bit more detail about that as well. There's pills options, which we've touched upon a little bit throughout these talks, but I'll kind of give you an example of a patient who's had a result with that. Radiation therapy, Dr. Ferris will be talking to you about that after. And then the infusion medications, particularly the immune checkpoint inhibitors, which you've heard about in detail before. So I'll be talking about the creams and the pill sorts of treatments. So topical treatments for skin cancer, the ones that we use the most and go for the most have been around for a long time. And the 2 main ones are imiquimod, also known as its brand name Aldara, and fluorouracil or Fudex. Often these are used for skin cancer prevention as well, so some of you may be familiar with that. But for low-risk skin cancers, they can also be used to actually try to treat the cancer as well. So when to consider using this? These are best suited for small superficial tumors in low-risk areas. So if it's close to the eye, maybe less likely to be a good option, because there is always a risk that they may not work as well, and we may need to have other types of treatments as well. So say you have a patient, say I have a patient here who has a superficial kind of more rash-like basal cell carcinoma, or an early squamous cell carcinoma in situ. You can see it doesn't look like it's very thick or going very deep into the skin. This would be a good patient to try to treat with topical treatment. What to expect during this treatment? Well, a cream seems easy, but they actually cause quite a lot of inflammation because they actually call the immune system to the skin to try to fight that cancer. And in the process, this causes a lot of inflammation. And so these creams have to be applied daily or several times a week for several weeks to even months, sometimes 3 months. And they cause quite a lot of inflammation, scabbing, rash, and burning and pain throughout the process. But once the treatment is done, these can be very effective. There's probably somewhere between a 70 to 85% clearance rate. And for many patients, that's a good, pretty good bet, especially if the skin cancer wasn't bothering them that much in the first place, to hopefully keep it at bay and let them kind of go on couple weeks or months of pain to kind of get through for more comfort down the road. And so this is an option that we turn to more often in some of our older folks. It's not for all older people, though. The patient has to be motivated and committed to actually sticking with the course of treatment throughout the pain and comfortable applying on a daily basis. And it's not for everybody in that there's pain. There's a higher risk of recurrence because we're not checking those margins and making sure everything is gone. And not all tumors will respond. We still don't understand why some patients respond better to these creams than others do. And some tumor types respond better to these creams than others do. So it's definitely worth having a discussion with your doctor or your dermatologist if this is the right treatment for you. The next thing I'll talk about is the pills that are used for skin cancer. And this has been touched upon before, but really there's one main type of definitive treatment that we like to use for skin cancer to make it go away. You've heard about prevention with niacinamide and acitretin, and then Dr. Haykel sort of touched on these hedgehog inhibitor type of medications. And so that's what I'm going to talk about today is the hedgehog inhibitor medications for actual shrinkage and attempts at clearance for these medications. So these two medications, they're in the hedgehog inhibitor family, and they're known by their trade names. Araveg or vismodegib is the generic, and Odomzo or Sonidegib is the other one. These two medications are made by different manufacturers, but are otherwise quite similar in how they work and their efficacy in patients. Of note, these only work in basal cell carcinoma, not squamous cell carcinoma. So squamous cell carcinoma will not respond to this medication, therefore it is not a good option. So who to consider for this sort of oral medication treatment? Well, we use these in difficult surgical locations. For instance, around the eye area where surgery is quite risky. And furthermore, for patients that have very bothersome and deeper type of basal cell carcinomas that are not going to respond well to the topical medications, and that surgery would also cause quite a lot of difficulty. It's also important for the patient to understand that these medications do not necessarily cure the cancer. In some patients, they may have complete clearance and the tumor may never come back. But in many patients, that's not the case. And so that it's very important to understand what we're getting into when we try to attempt treatment with these medications. So this is a patient that I saw, and you can see he's got a large basal cell carcinoma near his eye. And so surgery would be very difficult. And he decided to ultimately go on one of these medications. And the reasons for that is because when these medications work, they often work very quickly. So within 2 months, you can start to see that this scabby basal cell carcinoma has started to turn into a nice white scar, which is obviously much more preferable than this sort of non-healing wound. However, during the course of these treatment, these patients often experience quite a few side effects. Hair and eyebrow loss is extremely common in these patients. But what seems to be the most bothersome and difficult to deal with in many cases is they almost always have taste changes as well. This medication affects the taste buds very strongly, often causing a metallic taste or loss of taste sensation, which is very bothersome to patients. It can actually be so difficult to eat and make them so, averse to food that they sometimes will drop a lot of weight and be at risk for malnutrition. In addition, it also can cause some nausea and diarrhea, which can further compound this issue of trying to eat. And one of the other most common side effects that can be extremely bothersome is these very strong muscle spasms, cramps, Charlie horse type of symptoms, which happen on a daily basis, can be painful, and really can not be a very easy thing to deal with. It can happen when patients are sleeping and wake them up in the middle of the night. It can happen while patients are driving and make them, concerned about their safety while driving. So these things are not to be taken lightly. However, the benefits of this medication are that some patients do have clearance. This is a patient who, after 6 months, had complete clearance of his basal cell carcinoma, and over a year has still had sustained treatment. I will say that over a year without the tumor coming back is on the less common side, whereas many of these patients will have the wound start to open up, lumps or bumps start to grow, suggesting that the basal cell carcinoma has actually started to come back. And again, we can't predict who that's going to happen to versus not. But for the right patient, it is sometimes worth a shot to see if we can get that clearance. And so, as I mentioned before, the side effects of this treatment are not insignificant. And so just sort of what to expect, what we can do about these things. Sometimes we're using lots of other medications to manage the side effects. And in patients who are already taking a lot of medications, this can be a lot more to handle. And so this is just kind of an overview here. I won't go through it. But the point of this is that this often leads to frequent discontinuation. Many patients cannot tolerate this medication. So taking this all together, what I've shown you is for the right patient, some creams can be effective and can be a good treatment option. Oral medications like the hedgehog inhibitors can provide some relief, but sometimes it's not enough and some will still need more. Oftentimes we still end up having to do surgery in these patients when they don't respond to the treatment. We often will need to use radiation if the tumor comes back, or infusions with immunotherapy, as you've heard of before. So lots of considerations. There are options, but clearly this field still has a way to go for these non-surgical options. Hopefully we'll have more improvements in the future to update you on. Okay, with that, I'm always happy to take any questions. Please feel free to reach out or email me. Thank you so much. And we will move on to Dr. Ferris, who will talk to you about the radiation options for skin cancer.
All right, I'm excited to be here tonight. I am a radiation oncologist with the University of Maryland. You'll notice I'm quite outnumbered on this panel as the only radiation oncologist, and we're used to that. Skin cancers are really common, and most people with earlier stage skin cancers will never meet a radiation oncologist. There are great options, like you've heard already, to handle a lot of early stage skin lesions, and we'll just review some of the radiation techniques and how radiation fits in as an option for both skin cancers that haven't been treated surgically and sometimes skin cancers that need more treatment after surgery. Next slide. So why would radiation be used for skin cancer in general? One of the main reasons is for patients that aren't good surgical candidates. And what does that mean? That means patients who may have healing issues or issues with anesthesia, just patient preference. Sometimes patients have been cut on so many times, they just have had enough and want to explore an alternative option. And then another compelling reason to consider radiation is sometimes if the surgery is going to lead to quite a big cosmetic defect. And so some of these situations could be a spot on the ear, a spot on the nose, something like that, where removing the area with surgery, Mohs, something like that, would mean that a big cut is there that needs to be reconstructed. And so radiation can be a potential avenue to preserve the cosmetic appearance of that area. Cure rates are actually very high for radiation by itself for most early stage squamous cell and basal cell cancers, and it probably rivals surgery. Primary radiation therapy is usually not recommended for other less common skin cancer types like melanoma or Merkel cell carcinoma. And again, it's used after surgery for certain high risk features. Next slide. So electron therapy is a form of what we call external beam radiation therapy. And this is what most people think of when they think of radiation. It's when you go to a facility, there's a treatment room, and there's a machine that delivers radiation energy from the outside of the body. It feels like getting a scan. Electron therapy has been around for decades. It's sort of the tried and true standard for most skin lesions. It's very superficial. Electrons, if you remember from high school physics, are a very light particle. And so with that, they don't have the ability to penetrate very far into the body. They interact with a lot of the electrons that are also negatively charged particles in the skin surface. And so they just sort of ping pong around and can't penetrate further than a lot of that layer. So they inherently can only treat a few centimeters into the body, which means they're great for the skin surface because you can treat to the skin surface and spare a lot of the underlying structures because the energy doesn't continue to pass through. But it is a little more complicated to use electrons for more complicated geometric surfaces, such as in the head and neck area. Mostly electron therapy will cause just a skin reaction, and that's most radiation in general for skin cancer. But if there's nearby structures like eyes or nose or lips, then those can get irritated too. And sometimes we can use lead to actually block the electrons and make sure they don't penetrate into those structures. Next slide. This is what a radiation plan looks like. And so what we're looking at here is a CT scan, and this is a patient who had a large superficial basal cell of the left ear. And this is a radiation dose distribution. And so this is basically the therapeutic dose that we see going to the patient's ear. It's pretty superficial and doesn't continue to penetrate into the brain, which is deep to the target. Electrons, actually, their maximum energy is not right at the skin surface. So this wax structure that you see over the ear is sort of a device radiation oncologists use to artificially bring dose to the skin surface and make sure that you're getting all the dose you want to immediately at the surface and for a centimeter or so under the surface. Next slide. We can even use complicated techniques to treat sort of more complicated geometries, and this is actually an example of one of those wax structures that helps to shape the dose that's been 3D printed. So this, we scan the patient and send the images off to a company that then gives us this. It's called a 3D printed bolus, and it helps us to shape the energy and that needs to be directed. Next slide. And so when areas are too deep for electron therapy, you have to pivot to an alternative technique. And this is basically this curve you see on the right are sort of the energies of the different particles as they're able to penetrate into the body. And you'll see photon radiation is a common, widely available particle that most radiation facilities would have that allow for deeper penetration. There's usually sometimes more side effects with that because they do penetrate deeper. But if it's too deep for electrons, you have to pivot to one of these other techniques. Next slide. Skin brachytherapy is also known as surface radiation therapy. Is a technique that uses little applicators, so not the big machines that we use to deliver external beam radiation therapy. They're little applicators with usually a radioactive source that you can put directly onto a skin cancer and treat it that way. And they're great for small areas. They're great for complicated geometry like on the nose and things like that. And the downside to them is, unlike surgery, which is sort of a one and done procedure, they do require regimens that are more protracted. These brachytherapy approaches tend to be 2 to 3 times weekly. They can be anywhere from 6 to 20 treatments. External beam regimens tend to be even longer than that, which can be even like 30 to 30 or more daily treatments. And so convenience is sort of less so with some of these techniques because they do require a daily appointment, but there is no cutting and no anesthesia. Next slide. This is just one of the applicators that's widely available that you can place directly onto the lesion, and it delivers the radiation. Next slide. Here's another flexible applicator that you can actually shape, and you can cut this applicator and use however many beads that you need to in the grid. Next slide. This is an example of a case I did using that applicator, and this is just 4 small beads of this Freeburg flap put over this small basal cell next to this gentleman's eye. And this gentleman got 10 treatments. They were 2 to 3 times weekly and had an excellent response. Next slide. And that is just sewing the applicator into the mask. And so everything's nice and stable and repeatable on a daily basis. Next slide. That's what the dose distribution looks like. And you can see that we're treating the little target there, which is in the dashed lines, to the therapeutic dose, and pretty nicely sparing the eye, which is right next door. Next slide. And finally, I treat with proton therapy. This is not as widely available as these other techniques. These centers are very expensive and in limited locations around the country. But basically, this is a technique and an advanced particle that lets you do really anything you want with the radiation beam. You can shape it as desired. And so you can treat it as superficially or as deep as you need to while sparing the underlying tissues. It's particularly useful in the head and neck area. Next slide. This is an example of a radiation volume treated with proton therapy. So this patient had a squamous cell carcinoma on the tip of the nose and simultaneously had a lip lesion that had been resected by Mohs and needed postoperative treatment because of some high-risk features. And so we're painting the dose here so that we're treating curatively the squamous cell on the nose while treating the lip postoperatively. And you can see sparing the underlying structures, the mouth, the throat, the salivary glands very beautifully with this plan. Next slide. And finally, here's some differences in the dose distribution between proton therapy on the left and photon therapy on the right, which you can see is more penetrating. It just has some extra collateral dose wash that protons doesn't have. Next slide. And so in my view, surgery and radiation are complementary approaches. We work together, and often these decisions are done in a team-based manner. Certain cases might be preferable for one or the other, though there is some overlap. And that is my portion of the talk. Thank you.
Thank you all. And I think with that, we'll turn it over to the next session.
Excellent. Thank you so much for a really comprehensive talk about skin cancer management in the senior population. And so I'm very pleased now to actually start off our final session for this program, which will be highlighting promising clinical trials in non-melanoma skin cancer. So I can go ahead and invite our next set of speakers to go ahead and begin their presentation.
Thank you so much. My name is Catherine Herring. I am a head and neck surgeon at Ohio State. I'm thrilled to be leading this session on clinical trials in non-melanoma skin cancers. I'm excited to be joined by Dr. Aaron Burke, who's a surgical oncologist, also at The Ohio State University, and Dr. Sue Chandra, who's a medical oncologist at Northwestern University. Just a moment here, and I'll share my slides. Okay, so clinical trials are studies that test new treatments to find safer and more effective ways to fight disease. In skin cancer, emerging trials are focusing on the use of immunotherapy before and after surgery, of determining how we can personalize treatment for certain patients, using less invasive therapies, and potentially using alternative approaches in immunocompromised patients. To share recent emerging clinical trials, this is what our talks will be addressing today. So first, I'll be discussing some emerging data on how we could potentially shrink these tumors to allow us the opportunity to do less intensive surgery. Dr. Aaron Burke will then be discussing certain patient situations in which we perform surgery and discussing emerging clinical trial data to determine what we should be doing after surgery to reduce the chances of recurrence. And lastly, Dr. Chandra will be discussing the more high-risk population, which has already been addressed today, those patients who are immunocompromised due to transplant, and discussing this emerging data that discusses how we could potentially be using immunotherapy in these patients who were historically considered not candidates for this type of treatment. First, I wanted to present a case example to you. This is a 75-year-old male who's presenting with a cutaneous squamous cell carcinoma of the mid-cheek. On exam, there's concern for deep invasion into the cheek and the underlying saliva gland. So what would our treatment options be for this patient? Well, standard treatment would include a surgical resection, which would be a wide local excision, including removal of the underlying parotid gland. But it's important to note that there's some risks of this surgery. There's a very important nerve that runs within the saliva gland called the facial nerve, which functions to control the movement of your face. At the same time of that surgery, we would most likely offer a reconstructive surgery, which might require a flap or graft from elsewhere in the body. And as we just heard from our radiation oncologist, oftentimes for these advanced skin cancers, we would require radiation after surgery. So are there alternative options to this approach? Well, in 2022, a pilot study investigated whether we could potentially use immunotherapy prior to surgery to shrink the tumor and allow for less extensive surgery. In this study, patients were enrolled if they had skin cancers that were determined to be resectable or removable with surgery. These patients received up to 4 doses of immunotherapy, specifically cemiplimab, which we've heard about in this session so far. These patients had scans or radiology tests done after at least 2 doses of treatment, and then all of these patients underwent surgery. So in this study, there were 79 patients who were included. The most common tumor location for these patients was actually in the head and neck. And this is because these tumors occur in cosmetically and functionally important areas. And so providers and patients alike are interested in determining different strategies to do less surgery in these locations. This trial did not include patients who were immunocompromised. And these are the results from that study. Each bubble here on the right represents a different patient in the study. And those with the green bubbles are those who responded and had a complete response to immunotherapy prior to surgery, meaning they underwent surgery and had no tumor cells left in that surgical specimen. That's 51% of patients. Another 13% of patients had a major response, meaning there were just a few cancer cells left. Unfortunately, 10% had progression of their cancer during that time, but again, that represents a minority of patients. Importantly, this study looked at the side effects of treatment, and this has been discussed in prior talks today as well. But 82% of patients had manageable side effects, but 18% had more serious side effects. And again, these side effects of immunotherapy are very different from those side effects that we commonly witness in those individuals who receive chemotherapy. And that's because of the mechanism of action or how these drugs work. So what does this study mean? Well, it means that immunotherapy given prior to surgery can shrink or in some cases completely eliminate the cancer in over 50% of patients. This potentially allows for less extensive surgery, which improves quality of life and improves cancer outcomes for our patients. The study directly informed the design of a randomized controlled trial that compared this technique to the standard of care treatment approach, which would be surgery and radiation. And this is an ongoing clinical trial that is actively accruing patients at many academic centers. So to register for this trial, you would present to an academic center, and if you were determined to have an advanced skin cancer, you would be randomized to either the standard of care treatment arm, which would include surgery and radiation, or the neoadjuvant immunotherapy approach, which is that approach in which you get cemiplimab or immunotherapy prior to surgery. And then the surgery that you have performed is response adapted, meaning you may have less surgery than you otherwise would have if you had a good response to immunotherapy. This is one such patient that we have enrolled at The Ohio State University. You can see the pre-treatment photograph on the left side. This is a patient with a relatively small skin cancer, squamous cell carcinoma under the earlobe. But what's important is that on physical exam and his radiology test, this tumor was actually deeply invading the underlying saliva gland, which was again very close to that facial nerve. So we enrolled this patient on the study and he was randomized to the neoadjuvant cemiplimab arm. After 2 doses of immunotherapy, he had a complete clinical response with just a scar band remaining there. He received the total of 4 doses, and at surgery, after reviewing with pathology, he had a complete response to treatment, meaning there were no cancer cells left in his final pathology. So in summary, this study showed us that immunotherapy prior to surgery shows great promise for potentially decreasing the extent of surgery, decreasing the need for radiation, and ultimately improving outcomes for our patients. These randomized control trials are currently enrolling at many academic centers. And next, I'll give it to Dr. Burke to discuss the situation in which a patient may need additional treatment after surgery.
Thank you. Go to the next slide. So let's anchor our discussion in a case study. So a 55-year-old female presents with a greater than 10 centimeter fungating mass of the left breast extending into the axilla or armpit with surrounding nodules concerning for in-transit disease. Biopsy of the mass shows cutaneous squamous cell carcinoma or CSCC, poorly differentiated with lymphovascular invasion, and thus our working diagnosis at this point is high-risk CSCC. Next slide. So we obtain staging scans to make sure that there is no evidence of disease outside of where we know it already is. And that is exactly what these imaging studies showed, along with a, as you can see, relatively sizable and fungating mass in the area of the breast extending into the armpit. Next slide. So this patient undergoes a radical resection of the mass to negative margins with a delayed closure with an autologous flap by plastic surgery once pathology is confirmed for us that these margins are in fact negative. The patient then goes on to receive adjuvant radiation therapy to the surgical site, and we're left with the question of, is there additional treatment needed, or can we benefit this patient by providing additional therapy? Next slide. Adjuvant systemic therapy is medication therapy given after surgery to reduce the risk of local, regional, and distant recurrence. It is a strategy used in many disease sites. However, to this point, adjuvant chemotherapy for CSCC has not been shown to consistently have a significant benefit. Newer agents, however, many of which you've heard about tonight, have been shown to have success in patients with unresectable or advanced stage CSCC. And so, next slide, that led us all to wonder, could these new medications perhaps provide a benefit when used as an adjuvant therapy in patients with less advanced disease, but still high risk for recurrence after treatment with surgery and radiation therapy? And so 2 studies that we'll talk about next aim to answer this question. The first was the CPOST trial, which was a trial that enrolled patients with CSCC deemed high risk, as outlined by the high risk features in the lower left-hand corner. These patients underwent surgery and radiation therapy per standard of care, and then were randomized to receive either cemiplimab or placebo. The primary endpoint of this study was disease-free survival. Slide. What we saw was that there was a significant improvement in disease-free survival for those patients that received cemiplimab compared to placebo, with at 24 months, 87.1% disease-free survival for those receiving cemiplimab compared to 64.1% for those receiving placebo. Slide. There were increased adverse events in those receiving cemiplimab compared to placebo, but overall relatively limited and generally well tolerated, with only 10% of patients discontinuing therapy due to adverse events. Next slide. The second study is the Keynote 630, which is a study that similarly enrolled high-risk patients, with high-risk CSCC, but it is worth noting the definition of high risk here is different. It is broader than what we see in the CPOST study, and it's also outlined in the lower left-hand corner. These patients also underwent surgery with radiation therapy and then were randomized to a different medication, pembrolizumab, versus placebo. And the primary endpoint in this study was recurrence-free survival. Next slide. What's notable is we actually see the exact opposite in this study. There was no difference in recurrence-free survival in those who received pembrolizumab versus placebo for these patients. Next slide. It is worth noting that there did seem to be a significant increase in recurrence, however, in those patients that had placebo compared to pembrolizumab. This just did not play out into the disease-free survival results that we saw on the curves previously. Next slide. So what are we to make of this? We have two studies aimed to answer the same question with similar design, but completely opposite outcomes. And I think there's multiple possible reasons for this, and this has actually been discussed in many papers and opinion pieces. One of the reasons is thought to be related to the stricter definition of high-risk cutaneous squamous cell carcinoma seen in patients in the CPOST trial compared to the KEYNOTE. And when people try to do ad hoc analysis where they actually take the patients from KEYNOTE 630 that meet the CPOST criteria, we actually do see a benefit. So that could be part of it. There could also be differences in baseline characteristics between the studies. This seems less likely based on ad hoc analysis, but it's possible. There's certainly a difference in the primary endpoints in the study, and it's worth noting that the definition of recurrence-free survival in KEYNOTE also include any death from any cause. So we could be seeing death from other causes playing into this role. We wouldn't expect this with the randomization, but it is possible to have something like that happen. The timing of delivery of the adjuvant therapy is different. And as Dr. Herring has pointed out, perhaps it's about timing of the delivery of the medication, not just in the adjuvant setting, but perhaps it needs to be moved up front. There's also the possibility there could be a difference between these medications, although overall that seems to be a little bit less favored. Next slide. So what do we do now? Two opposing studies for the same topic. Well, I think our approach is really as we often talk about going back to, a multidisciplinary approach. I think that certainly there needs to be careful consideration of the use of these agents in the adjuvant setting, so that we can provide the greatest benefit while reducing the risk of overtreatment. And using a multidisciplinary approach should help us do that. We did, in fact, recommend adjuvant cemiplimab for the patient presented today, as they fell well within the CPOST criteria of our highest risk patients. I think we need to consider to work on this, study this, understand these results, and look into new approaches like perhaps moving this therapy up front, as Dr. Herring pointed out.
Great, thank you so much. And then we'll move on to Dr. Chandra to discuss the management of solid organ transplant patients with advanced skin cancer and the recent clinical trial data regarding this.
Thank you so much. I'm Sunandana Chandra. I am a medical oncologist at Northwestern. I'm actually following Dr. Warden's great talk and background on our patients who are immunocompromised, specifically with a solid organ transplant. And I'll be just going into a little bit more depth into some of the trials that Dr. Warden had previously mentioned. So let's start off with a case, just to kind of put this into context that might hopefully make sense. So this might be a typical patient that many of us in medical oncology might see. So the person is 59 years old, has a history of a kidney transplant, has been on chronic immunosuppressants. These drugs are essentially given to protect the transplanted organ from becoming rejected by a person's own immune system. So this particular patient presented for further management. They are not interested in chemotherapy. They said that right up front, and they are inquiring about the usage of immunotherapy. Next slide, please. So just as a reminder, as Dr. Warden had said, cutaneous squamous cell carcinoma specifically in solid organ transplanted patients has an incidence that is 65 to 250 times greater than the general population. And in fact, makes up about 40% of cancers that we see in patients with solid organ transplants. So it represents a pretty significant number of people. So in general, patients with solid organ transplants were always excluded from immunotherapy trials. And the reason for that is there was concern that because we're trying to rev up a person's immune system by using immunotherapy, it might actually do harm to their transplanted organ or their graft, as we call it. And the risk of that we've been able to kind of show in general is almost about 50%. So it's kind of a coin toss on whether if I do treat someone with immunotherapy, if they will lose their transplanted organ. Now, there have been some trials as of late that have actually looked specifically at this very special patient population and tried to understand if immunotherapy can in fact be used. Next slide, please. So the first of these trials was the ETCTN 10214 trial. This was a multi-institutional trial where essentially the patients were prescribed a very specific immunosuppressive regimen. They were asked to take an immunosuppressant drug called tacrolimus and prednisone of a very low dose every day. They were then treated with nivolumab once a month, and at the 12-week mark, they underwent scans. At that time, they were then determined to have a particular response, whether it was a CR, a complete response, a PR, partial response, SD, stable disease, or PD, progression of disease. Now, if they had some sort of response or stable disease, then this patient would then continue with more nivolumab for a total of 2 years. On the other hand, if at that 12-week mark, they saw that the person's cancer was not responding to the immunotherapy, then we actually switched their regimen and added a second immunotherapy drug called ipilimumab. And the person then went on to get treated essentially for up to 2 years with some modifications with that ipilimumab nivolumab dosing. Next slide, please. Now, the endpoints of the trial were to look at response rate and to see if there was graft loss or the loss of the transplanted organ. In this situation, just a reminder, all of these patients underwent a kidney transplant in the past. And as you can imagine, the reason this particular patient population was studied in this trial is because if one were to lose their kidney transplanted organ, although that is not at all our goal, but if one were to do that, they could still go on to dialysis and still have hopefully a reasonable quality of life, as opposed to one with a heart transplant or pancreas transplant or liver transplant. If those transplanted organs fail, there really is no quick fix, so to speak. So back to this trial. So in the patients, if you concentrate on the first 4 columns or so under nivolumab, you see that every single one of these 8 patients had a PD or progression, and one of them lost their graft. So because they all had a progression, they all actually then went on to receive 2 immunotherapy drugs, as I'd mentioned on the slide before. And then you see in the second to last column under ipilimumab nivolumab, or ipi-nivo here, that 2 of those patients highlighted in that kind of bright highlighter green had a CR that we call complete response. So that means in those 2 patients, once ipilimumab was added to their nivolumab, they actually had a complete disappearance of their metastatic cancer. In this situation, one of them had metastatic cutaneous squamous cell cancer, and then the other one had another situation where they had metastatic cutaneous squamous cell carcinoma. And out of the 8 patients, 2 of them actually lost their kidney transplanted uh, uh, organs or their grafts. Next slide, please. This is just a photographic kind of description of one of those patients. So if we start from left to right, this is a particular person who was 69 years old, had a kidney transplant many, many years ago in 2008, had then an unresectable cutaneous squamous cell carcinoma on their left temple. And here you see, prior to starting therapy on the far left, there was actually a significant amount of cancer. When we did the biopsy, there was very few lymphocytes or T cells in the actual specimen. In the second column, we had given them nivolumab, and despite treating them with nivolumab, the tumor did not shrink, or the cancer did not shrink on the temple, and nor were there increased immune cells in that biopsy after 4 weeks of immunotherapy. Now, if we go to the third column, this is when we added ipilimumab, and you see that there's a little bit of shrinkage. Actually, sorry, quite a bit of shrinkage, and there remains 10% residual viable tumor. That's what the RVT stands for. And on the bottom, you see suddenly there are more T cells. And these are subsets of T cells that we follow. They're called CD4, CD8. But the point of it is not only do we see tumor shrinkage when we give 2 drugs, but also increased T cells. And then in the fourth column, at 8 weeks of ipilimumab, nivolumab, you see complete shrinkage. You do see some scar tissue, but biopsy-proven complete shrinkage. And again, more T cells. Next slide, please. So this is the second trial that looked at this very unique patient population, people with advanced cutaneous squamous cell carcinoma who'd had a kidney transplant. This trial, as was previously mentioned by Dr. Warden before, known as the contract trial, was completed in one institution compared to the other one completed in multiple institutions. And here they actually looked at pulse dose of prednisone, higher doses than the last trial, and a different type of immunosuppressant drug called either everolimus or sirolimus that falls under the category of mTOR inhibitors. And here their primary endpoint, their objective was to see if they could decrease the rate of transplanted organ rejection. Next slide, please. I'm just going to kind of walk you through this. So this is a typical way that we analyze data. On the far left, all the blue bars that are pointing upwards are showing where tumors have actually grown. All the blue bars that are pointing downwards are showing tumors are shrinking. In the second column, this shows that over time, on the bottom axis, you can see all the months that have gone by. There are a number of patients who continue to have a response up to 14, 16, 18, 24 months. So it shows you that there's a durable response. And then finally, in the interest of time, I'm going to skip to the final. Here is a radiographic picture showing you that the temple mass actually shrunk from the one on the left compared to the one on the right. So I hope that these 2 trials were able to show you that perhaps there is some hope that using immunotherapy in this transplanted transplanted patient population may actually still be safe. We just have to be very transparent with our patients about risks and benefits. And but I think it's promising that we have some new drugs that we might be able to offer, something that we would not have been able to offer just a few years ago. Thank you so much.
So in summary from this session, I hope that you will take that immunotherapy before or after surgery is changing how we treat advanced skin cancer, potentially reducing the extent of treatment. And even in patients once considered too high risk, we may now have immunotherapy options. I truly believe that the future of treatment of skin cancer is personalized, meaning biomarkers, which are markers in a patient's specific tumor or blood, for example, as well as targeted approaches will help match each patient to the right treatment. And enrolling in a clinical trial is not considered a last resort, but rather it is an opportunity to access the most advanced care. Thank you so much.
Excellent. Well, I just want to say thank you all so much for the speakers this evening for um, taking time out of their certainly busy schedule to sort of lend some of their expertise for tonight's session. And so I will start to hand this off to Anne, who will make some final words before we transition over to our Q&A session.
Okay. Thank you, Dr. Ma. And I know in the interest of time, we want to get to QA as soon as possible. So I also would like to thank all of our panelists. Those were wonderful presentations. And I'll invite you to go ahead and turn on your cameras while I talk for just a minute about AMIT melanoma and AMIT skin cancer. For those that are watching with us this evening, if you're not aware, AMIT melanoma was founded 21 years ago. And during that, since that time, we've been dedicated to funding programming that's likely to advance a cure and offers the greatest support to individuals living with melanoma. Then 2 years ago, largely at the behest of the public, we launched AMIT Skin Cancer so that we could offer the same programs and resources for individuals who were diagnosed with non-melanoma skin cancers. All of our resources, both on AMIT melanoma and AMIT skin cancer, are available at no cost. And I'd like to tell you about some things that are on our AMIT skin cancer website that I feel are noteworthy. The first is that we have sections dedicated entirely to basal cell and squamous cell carcinomas, and they feature information on diagnosis, related treatment, side effect management, and available clinical trials. We also have a service that's called Ask a Skin Cancer Nurse. Krista Rubens is an oncology NP with 30 years experience. There's a form there that you can fill out. She is not going to change your plan of care, but rather she's going to try to make you understand the recommendations from your care team, or perhaps help you to understand the results of a test that you have had. Krista also hosts webinars with cancer experts on a wide variety of topics. Two examples of two that she's done recently are understanding skin cancer in older veterans and also the genetics of skin cancer. And those are located in our video library. Also in our video library are our symposiums. We co-host 4 a year. What happens with our symposiums, like the one that we are recording this evening, is first of all, we offer its entirety on both our AMIT melanoma and AMIT skin cancer YouTube channels in about, 15 minutes or so. The entire symposium will be available again for you to watch. In addition to that, we'll take each one of the presentations, edit them and divide them, and then place them in our video library by topic. And then the last thing I want to make sure that you know about is our image gallery. We have 50 images of a wide variety of forms of skin cancer, both melanoma and non-melanoma, on people of every age and every skin tone. It is by far the most frequently accessed page on either of our websites. In just 2 years, our image gallery on AMIT skin cancer enjoys 35,000 views a month. And we know that people are coming to that because they're typing into their search engine, what does skin cancer look like? And so we're so glad that they're finding our image gallery and it's useful to them. And so with Dr. Ma and Dr. Weiss's permission, I want to be first. I want to be first in line for Q&A. And I have a question for our panelists. So what I think people are doing when they come to our image gallery is they're looking for red flags. They want to know, what I found something that looks atypical. And what's a red flag for me? When do I need to get to the doctor sooner rather than later? And so I guess that's my question to you is, how should they be using any information that they glean from our image gallery?
Well, maybe I'll take this one. So, no, I think that if any patient thinks that something matches what is in your gallery, they should immediately try to get an appointment to see a doctor that could do a biopsy to diagnose the condition. Even if it looks benign, sometimes people are really tricked, especially with melanoma, and it turns out to be a melanoma. So it's better to do 10 times for nothing than once too late. Sometimes it's hard to get the right appointment to the right doctor, so you may have to work through your PCP and push the PCP, unless when they see the lesion, they know it's totally benign, like a seborrheic keratosis or something like that. But if there is any suspicion, it needs a biopsy, even in a 20-year-old.
The other thing I would add is just any lesion that's changing. So if you look down at your skin and all of a sudden you notice it looks bigger, or it has different borders, it has multiple colors, it just looks different in general, like it's changing in appearance, that would be a reason to see a dermatologist or a biopsy. And then also any associated symptoms. So if a spot starts bleeding, it's scabbing, or it's kind of a non-healing sore that you've tried to, let it heal and it just keeps breaking open. Any of those symptoms would also warrant a biopsy or seeing a physician to have it evaluated in person.
So we do have some great questions from the audience, and I can transition into the next question, which is a good question for some of our dermatologists here. So the question is, I am 74 years old and I just had a spot taken off my lower lip. I'm wondering if this is just age related. Will sunscreen really make a big difference at my age? So maybe we can hear from some of our panelists about the impact of age on, skin cancer development, and when and how sunscreen is impactful.
I can take that, I think, and you do start to develop skin cancers oftentimes a little later in life. It may partially be due to prior skin insults and UV or radiation from earlier in our lives. But there's no reason to add insult to prior injury. So no one should be trying to go out and get a tan or activate those cells into doing something bad to them down the road, whether you're 74 or 85 or whatever. You just don't want to activate them, and then you have more than you otherwise would have.
I'll also say too that in many patients who have a lot of precancers who start to diligently use sunscreen, we will often see that those precancers will start to clear up on their own with sunscreen use alone. And part of that is probably because we have an immune system in the skin, as we have learned, is very active and important for keeping cancer at bay. And I think that, we sort of think that if the sun keeps beating down and causing more damage to the skin, the immune system can't keep up quite as well. But if sunscreen is put on, it can kind of help, bolster that immune response to let your own immune system kind of work on those skin cancers in the background. So I tell patients it's still worth doing, even if the damage has already been done, when in your youth. So there's also that.
Excellent. Well, I'll also bring up the second question. This is a question that was actually brought up prior to our program this evening. It was a patient or a person who was inquiring about whether or not we'll be talking about clinical trials in skin cancer. So this might be a good question for our speakers who highlighted some of the trials in non-melanoma skin cancer. How, if a patient comes up to you or family or loved ones come up to you and they're asking, how do I sort of apply, for these studies? How can I sort of explore, clinical trial options? They're very curious about some alternative and breakthrough methods, in terms of their care for skin cancer. what would be sort of your advice that you might have for this person or even a patient?
My advice for patients would be to, present to a larger academic center. That's oftentimes where these clinical trials are active and able to enroll you as a participant in the trial. There's many academic centers, several in each state, and so I think presenting to one of those centers, either to a medical oncologist, surgical oncologist, who can talk to you about which of those trials you may be a candidate for.
I'd also say that the NCI has a list of ongoing trials that you can search, and many of the academic centers also have search engines within their own websites that you can search for clinical trials that just by keywords, so disease site, and then it'll pull up all of the clinical trials related to that specific disease site. On the NCI sites, they will list the locations that are active in those trials. And then, of course, if you're at an institution's website, they're listing the trials that they often have open at that site. So a couple different ways to search for these trials as well, prior to maybe presenting as in addition.
Great. So we'll move on. We have a few more questions. So the next question, I think, is a question maybe for some of our medical oncologists about treatment for squamous cell carcinoma. So the patient has been told that they need immunotherapy for a recent diagnosis of squamous cell carcinoma, and they want to understand how can they understand the difference in the effectiveness or side effects of the options of the therapy. How would you counsel the patient, and what information can they have to kind of make their decision about therapy?
It's a very broad question because you're a medical oncologist as well, so it really depends on the presentation of the skin cancer. It depends on the medical history of the patient. So it's really a therapy approach that needs to be deeply thought so that in the end it will benefit the patient with the highest likelihood possible and the least side effect possible. And it's not something that you can just give boundaries or just a recipe on how to proceed. I think you really need to have a discussion with your medical oncologist and look at all the options possible for the type of cancer and the presentation and your medical history background, and then decide what has the highest chance to help the cancer, or to not help the cancer, help the patient get rid of the cancer with the least side effects possible. So it's a balance there that one needs to discuss with their physician. But there is any treatment has risks, and so we can't really change those. And unfortunately, we cannot predict who's going to have those side effects. If we could, it would be much easier, but we cannot.
Excellent points, Dr. Verstraegen. So, I know we're sort of running quite late this evening, especially with the symposium. So we'll sort of finish off with this last question here. Again, a question that was posed before the program this evening, which is, and this is something that might be well posed to maybe their dermatology colleagues, but, are there, any research right now sort of connecting things like weed killer, like Roundup, or any potential environmental exposures such as chemicals and its ties or links to the development of skin cancer?
I can answer to some extent that question. I think it's a really great question because people often think of skin cancer as being sun related. And I always tell patients sun is definitely the biggest risk factor for skin cancer, but it's not the only risk factor for skin cancer, which is why, when we do a full skin cancer screening, we will check non-sun exposed areas between the toes and, genital skin. So other risk factors for skin cancer include other types of radiation. Interestingly, trauma to the skin can sometimes precipitate development of a squamous cell carcinoma or something called a keratoacanthoma. In terms of the question about Roundup and those sorts of chemicals, I'm not aware of any link to skin cancer, but I do think it's important to realize that sun isn't the only culprit responsible for the development of skin cancer.
As far as things like Roundup, that's they're trying to make an association that maybe that has something to do with lymphoma, which there's cutaneous lymphomas that can occur too. But I think the data is not particularly compelling as of now. The other thing, we don't have arsenic in much of the things that we're exposed to these days because it was found arsenic can induce squamous cell carcinoma. So, I mean, that's just one though.
Very good points. I think, with skin cancer being so obviously prevalent here in the US, there's certainly an unmet need to sort of explore other factors beyond UV sun exposure that predisposes patients to skin cancer. So Anne, unless you have any other final thoughts, I think we'll go ahead and just wrap up this evening. So just some final words from myself. We hope this program certainly provided helpful information, some practical guidance, and obviously a multidisciplinary support for those who are affected by skin cancer. I'm obviously, and we are obviously grateful for our wonderful speakers for volunteering their time again to participate and speak at tonight's symposium. We would like to sort of extend a special thanks to the AIM at Skin Cancer Foundation, including Ann Gast, as well as Sam Guild for their partnership and leadership in patient education, and as well to the Big Ten Cancer Research Consortium team, Randy Dillinger, as well as Jonathan Ang, for helping to kind of bring together our experts from across multiple institutions for this collaborative event. And so we hope that this will be sort of the beginning of a continued educational effort, as well as a collaboration to better help support our patients affected by skin cancer. And so we wish you all a wonderful evening, and please take care of yourselves.